సందీప్ గారు ప్రమోషన్
Ma'am,
సైట్స్ ఫస్ట్
promotion stats leave, ma'am.
Yeah.
Shall we start, ma'am?
Yes.
You can start, ma'am.
Hello, everyone. We're back to our class on an Auricle platform. So today's ENT class will cover the topic Meniere's disease, a very important topic in ENT in your clinical practice and also for FMGs. So we'll just have a brief introduction about our topic for today. We'll cover a long essay. What is actually Meniere's disease? How will you describe the causes of Meniere's disease? What is the pathology, clinical features, diagnosis, and management of Meniere's disease? And what is the difference between Meniere's disease and Meniere's syndrome? Talking about Auricle, we have 5 platforms where we can see we have recorded classes, we have live classes, practical sessions where we'll teach you for your practical exam. We have exam modules and hard copy book sets. Now, recorded classes will be recorded. It will be a flexible learning done by an expert instructions, and you will have a convenient revision whenever you want to come back to the topic and reread it again. And then we have live classes like this one where we can have one-on-one sessions. We'll send you polls and quizzes where you can solve the quiz and then correlate your wrong answer with the topics that we are going to explain you ahead. So we have a live session where you can have one-on-one question answer sessions as well. Now, Express Exam module is like a crash course for those who have already prepared for the subject and the topic and ready to write for their final exam. So it's a 20-hour course crash where we will teach you how to present the exam in the exam, answer in the exam hall, and all the tips and tricks and all the perks that you should know to sit in the exam hall. So it's like a complete syllabus in just 20 hours now. This is only for people who are already done with their subjects. It's not like, you don't study the whole year and then come get this crash course. It's not going to make any sense for any one of you. Now we have one-to-one on doubt clearing sessions, where it's usually a student-centric approach. The students can ask us questions, clear their doubts about any specific topic that they have, and just clear the doubts that they are in. Now, hard copy note sets are made by experts. It's the extraction of the information and required questions, required topics that you have to study, and what else and how you have to write in the exam hall. So it's like a supplement to a textbook. You can use it as a note to know how you have to present the exam, the answers in the exam hall. We have a question bank as well. Now it's like a 3-level expert question bank. Like we have beginners to expert level. You can customize the question bank, download it in your Apple Android applications or in your tablets. And, it usually covers MCQs for academics, for NEET PGs, and also for FMGs. Now, we also train students for practical sessions. It's a hand-on experience. Usually, we use an expert guidance, and we have an Excel in practical examination. We excel the students for their practical examination, like how you have to present yourself in the exam hall and how you have to, hold the things, like if, for example, if you're in an anatomy practical session, how you should hold a bone, and all those things will be taught you in a very detailed manner. Now we have a subscription plan for 4 types. First 2, you don't have all the privileges, like you don't have hard copy note sets and you don't have a doubt clearing session. But the other 2, that a complete learning plan and an ultimate MBBS plan, you will have that, all those perks of having that. And you can use a code DRNAWALMOHEMMED20 for a discount on your subscription. Now, coming to the point, this is the anatomy of your The main thing that you should know for an ENT, we have an external ear, inner ear, and a middle ear, right? Yeah. So before this, we'll have a poll, right? We'll flash the poll questions on your screens, solve the polls, and then we'll move ahead for the topic for today. So we are going to have a poll in few seconds. Yeah, it's there on your screens. Okay. Now I'm going to end the poll. We just had 5 questions so that we can move ahead with the topics. Now, so this is the anatomy of the ear, outer ear, middle ear, and inner ear, right? So today's topic is Meniere's disease. So Meniere's disease happens here. Okay. So it's somewhere in the middle and the inner ear part. So this is where you will have Meniere's disease. So this is the location of Meniere's disease, usually seen in semicircular ducts. Now, what is Meniere's disease? So Meniere's disease is actually called as endolymphatic hydrops. Okay. It's an endolymphatic hydrops. And here what happens is that it is usually a disorder of inner ear where the endolymphatic system gets distended with the endolymph. Now, it is characterized by 3 things that everyone should know. Actually 4, but 3 things that everyone should know is vertigo, sensory neural hearing loss, and tinnitus. Okay? So the main thing that everyone should know is vertigo, tinnitus, sensory neural hearing loss. Now, these patients can also have oral fullness. Now, we'll come to that point that why do they feel oral fullness? Because that's the main point of the topic. Now, when you have a pathology, the main pathology is distension of endolymphatic system. That will mainly affect the cochlear duct. So here, what actually happens is that this is your endolymphatic sac, right? And here you will have endolymphatic enlargement. That's the bulging of endolymphatic system. Now, when your endolymphatic system bulges out, it will interrupt with the acoustic nerve and it will affect your hearing. So that's why the patients with Meniere's disease will have sensory neural hearing loss. I repeat, the patients who are having Meniere's disease are usually having sensory neural hearing loss. It is because the endolymphatic sac is usually enlarged, and this will affect the acoustic nerves that will lead to sensory neural hearing loss. So the main pathology is that when your endolymphatic system distends, okay, it mainly affects the cochlear duct. So let's go back to this diagram. Now imagine your semicircular canals. This is your endolymphatic system, right? Now this is getting distended. Now, it will start affecting your cochlear system here. Okay? It will start affecting your cochlear duct. So, in cochlear duct, you have scala media that is usually affected. So, I'll write it down here. Okay? Scala media. That is usually affected, and the saccules are also involved. So, in lesser extent, what happens is that the utricles and semicircular canals are also involved. But the main thing that is involved is cochlear duct. Okay, and then you have saccule. Now, the dilation of cochlear duct is such that it may completely fill the scala vestibuli, and that leads to the bulging of Resner's membrane. So, this is the diagram that is required. So, you can see here, this is Resner's membrane. And what will happen that you will have a distension of Resner's membrane. So, when you have a distension of Resner's membrane, right, bulging of Resner's membrane, that might herniate into the apical septum of scala tympani. So this is scala tympani, scala media, scala vestibule. So when this Resner membrane is distended, right, it enters into the tympani part, and that will herniate, and that it will form an apical, that will be into the apical part of scala tympani. The distended saccule can sometimes lie against the stapes foot plate. So let's go back to this diagram. Okay. So let's imagine that it is somewhere here, right? So it will lie against the stapes foot plate. And this is also actually a pathology of Meniere's disease. So the utricle, the scala, saccule may show outpouchings into the semicircular canal, right? So if you have utricle and saccule involved, they might also show outpouching into the semicircular canal. So this is the pathology of Meniere's disease. Remember that it is an endolymphatic hydrops, we say it. Three main symptoms are vertigo, tinnitus, and sensory neural hearing loss. Sensory neural hearing loss is because it will affect the cochlea. It will also affect the acoustic nerves that will lead to sensory neural hearing loss. Now, what happens is that the Resner membranes gets distended, and it will form an apical part in the scala tympani, right? From the scala media, it will move in, it will distend into the scala tympani. Now, etiological factors, the main factors that are the reason for Meniere's disease is that the distension of endolymphatic system is because of the increased volume of the endolymph. Okay, so there will be increased endolymph volume. Okay, this will lead to the increased production of endolymph, or maybe because there will be absorption dysfunctioning. It's either, now, if the increased volume of endolymph, the endolymphatic volume increases, it will lead to increased endolymph production. Or there will be absorption dysfunctioning. Normally, what happens is that the endolymph is secreted from stria vascularis that will fill the membranous labyrinth and usually absorbed through the endolymphatic system. I repeat, normally what happens is that the endolymph is secreted by stria vascularis that will fill the membranous labyrinth, and it is absorbed by the endolymphatic sac. But yet, the exact cause of Meniere's disease is not usually known. The main thing that you should all know is that you have to just by heart this table that's there on your screen. That Meniere's disease is endolymphatic hydrops, and we have episodes of vertigo, we have fluctuating hearing loss, we have tinnitus, and we have oral fullness. Now, these are the clinical features of Meniere's disease in short, right? Now, what are the causes? It's either because of defective absorption, or it's either because the patient is having any food allergy or inhalant allergy, or it is either because of autoimmune process, or because of some viral infection, or there is some stress like vasomotor disturbances in patients, sodium water retention, and endocranial conditions like hypothyroidism. Now, the Meniere's disease is usually seen, yes, this is evident that Meniere's disease is usually seen in patients with hypothyroidism. They will complain of ear fullness. Okay, so this is all in all. We have covered the pathology and etiological factors in one place. But remember that you should mention that increase in endolymphatic volume will increase the endolymphatic production, or usually when there is faulty absorption or both, then you have something called Meniere's disease. Now, here again, we came to the pathology, defective absorption by endolymphatic sac. You can see it on your screens, right? So what will happen is scala, media, saccule, and utricle and semicircular canals are used. Normally, endolymph is carried by endolymphatic duct, and from there to the sac. From sac, it will get absorbed. But now, if there is defective absorption by the sac itself, it will increase the pressure of endolymph. And this will lead to obstruction of endolymphatic sac and its ducts, and this will produce hydrops. Normally, what happens? The endolymphatic duct is carried, endolymph is carried by the endolymphatic duct to the sac. Okay, there it is actually absorbed. But if there is a defective absorption by the sac itself, that is responsible for the raised endolymphatic pressure. This will lead to endolymphatic sac obstruction, and it will lead to hydrops. That is important. Now, bulging of Resner's membrane. What happens here is that there will be bulging of Resner's membrane, and the Resner's membrane will herniate into scala tympani, just like I told you, and the distended saccule may become to lie against the Stapes foot plate. I have explained this already. Now, the utricle and saccule may show outpouchings into the semicircular canal. Now, if there is distortion of cochlear duct, that will cause hearing loss. Now, which hearing loss will this be? Sensory neural hearing loss. Okay. The Librinet will cause vertigo. So you can see very clearly, we have inner ear in Meniere's disease, a very good diagram, and you have a bulged endolymphatic sac. Now it is also compressing your acoustic nerves here, right? It is distended endolymphatic sac, affecting your cochlear duct and acoustic nerves. And this will lead to distortion of sound information and all those things. Now, the patients with Meniere's disease, coming to the point, age and sex. So these are usually seen in patients with age group of 35 to 60. Some have an advice that can be 40 to 60. Okay, usually males are affected. This is just for your general knowledge. But then the top point here you should take is that the patient will have episodic vertigo, tinnitus, and hearing loss. Meniere's disease. So these symptoms you should remember. This is usually asked in the exam hall. What are the symptoms of Meniere's disease? You should be able to say it is episodic vertigo, hearing loss, and tinnitus. Now, which hearing loss? Sensory neural hearing loss. So vertigo, it is usually sudden in onset. Comes in attacks. It is sudden in onset. The patient will feel like the rotation of himself. He will not feel that his environment is moving. Usually it is the rotation of himself or his environment. Okay. Or there might be a feeling of a pendulum, a to and fro movement, or an up and down movement. So the vertigo is like an abnormal feeling or sensation of abnormal movement. Now, these attacks can come in clusters with periods of spontaneous remission that will last for weeks, months, or years. Depends. Years are usually rare. It is usually lasting for weeks and months. Now, these patients will have vertigo plus nausea, vomiting. Okay. They will have clusters of headache, cluster of vertigo, accompanied by nausea and vomiting. A very important thing is the nystagmus. What is nystagmus? It is movement of the eye, right? So severe attacks can also, now why does this patient have nausea and vomiting? Well, because what happens is that you will have a vagal disturbance. And that will cause abdominal cramps and that will cause diarrhea. The patients will have bradycardia and then they will vomit. Okay. So there is no warning symptom. Remember, vertigo in Meniere's disease is sudden, comes in attacks, comes in clusters. The patient will have to and fro movement or up or down movement or within himself, right? They will have nausea and vomiting and nystagmus along with vertigo. Why? Because there will be vagal disturbances. The vagal nerve might get stimulated. That will lead to abdominal cramps, diarrhea, bradycardia, followed by vomiting. Now, there's something called Tulo phenomena. So in some cases of Meniere's disease, they might show a phenomena called Tulo phenomena. In this condition, what happens is that the patient will have loud sounds. So where the loud sounds or now noises produced, they will produce vertigo. So if the patient is in a disco, right? Or let's say you're screaming around the patient of a Meniere's disease, he will start having an episode of vertigo. And this is because of the distended saccule that will lie against the stapes foot plate. So now we have mentioned that in some cases, what will happen is that the saccule will lie against the stapes foot plate. So now this is a hint what you can get. If the patient with Meniere's disease is having a Tulo phenomena, where you say that the patient, if he's induced with loud sounds and noises, that will produce a vertigo, then that's a hint that he might have a distended saccule that is against the stapes foot plate. Now, this phenomena is when there are three functioning windows in the ear. Okay, three functioning windows like fenestration of horizontal canal in the presence of mobile stapes. Okay, if there is a fenestration of horizontal canal in the mobile stapes, and you will have this phenomena. So here you can see loud noise will cause vertigo. Coming to hearing loss is usually sensory neural hearing loss that will precede vertigo. Okay. Now it will improve after attack. So these are usually the patients will have hearing loss only when they have attack and maybe normal during the periods of reemission. So they might have sensory neural hearing loss only when they have an attack. So this is a very characteristic of Meniere's disease. So actually, when there is some hearing loss directly, then the patient will have a constant hearing loss. You say, I cannot hear 24/7. But these patients will tell you that we are not able to hear after the stage of vertigo. That is a characteristic of Meniere's disease. Okay. So fluctuating hearing is mentioned. Okay. This is a characteristic of Meniere's disease. What else do I have to say? Okay. So what happens in hearing loss is that every attack will lead to slow and progressive deterioration of hearing loss. So it's not like, it stays within the point. Like first attack, the patient, the first time, let's say the patient had vertigo for the first time. And then after vertigo, he had hearing loss. If he has next attack of vertigo after a month, and then he has a hearing loss, that hearing loss will be worse than the first hearing loss. So it's like a deterioration of hearing loss, and eventually that hearing loss will become permanent. So it is a progressive, fluctuating deterioration of hearing loss. So the patient will have distortion of sound and he will have intolerance to loud sounds. So the patients of Meniere's disease will not be able to tolerate loud sounds because of recruitment phenomena. And they are poor candidates of hearing aid. We say that they are poor candidates of hearing aid because they are not tolerant to hearing loud sounds. They will not be able to hear music. They will not be able to hear high frequency sounds because that's the phenomena they are with. Okay. Now, I'll leave oral fullness for now. Coming to the point of tinnitus. Tinnitus in these patients will be low-pitched, roaring time, aggravated, especially during attacks. So now everything that happens here is during attack. Vertigo happens during attack. Okay, hearing loss is followed by vertigo, and then tinnitus is also ringing of the bells in the ear. That's tinnitus. So that actually happens during attacks. So it is usually a low pitch, aggravated attack during attacks, and they might even persist after hearing improvement. So now this might stay. These both might go away, hearing loss and vertigo. But tinnitus might stay in some patients. And all these symptoms of Meniere's disease are usually unilateral. Okay. Now, oral fullness is again fluctuating in nature, and this is also precedes an attack of vertigo. So everything happens after vertigo. So what's the first symptom that you will see in a Meniere's disease? You will see vertigo, then the hearing loss follows it, then tinnitus follows it. In some cases, the tinnitus will stay after the hearing loss, and then in the last resort, the patient will have oral fullness. Okay, so these are important symptoms of clinical features and symptoms of Meniere's disease. Now, how will you diagnose this patient? What is the examination that you will do in these patients of Meniere's disease? So, otoscopy. When you do an otoscopy, you will not see any abnormality in the tympanic membrane. It is not the disease of external ear or a middle ear. It is usually a disease of inner ear. So when you do an otoscopy, there will be no abnormal. Now, nystagmus is usually seen when the patient is having attack. It will not pertain, it will not stay. It will go off with every episode of attack. So it is the quick component of nystagmus is towards the unaffected side. So let's say you have the patient is having Meniere's disease on the right side. Nystagmus will be on the opposite side. It will be on the left side. Now, it can be horizontal or vertical, right? But it will be on the opposite side. The patient will have nystagmus on the left side. Now it can be like this or it can be like this. Now, when you do a tuning fork test, you will see that there is a sensory neural hearing loss. So what does it mean by sensory neural hearing loss? It is Rennie test that is positive, right? Absolute bone conduction is reduced in the affected ear, and Weber test is lateralized to a better ear. Let me write it down for you. When you do a Rennie's test, it will be positive, right? Rennie behind the penny, you vibrate the tuning fork, you keep it behind the ear on the mastoid bone. Now, when you the absolute bone conduction is usually reduced on the affected ear. Bone conduction is reduced. And what happened? In the Weber test, when you vibrate the tuning fork and you keep it on the frontal bone or on the parietal bone, what will happen? It will be lateralized to the better ear. Okay. So what's there on your screens? On your screens, it says that when you have to do a diagnosis, the possible is not definite. A possible is not definite episode, right? So it is an episodic vertigo without hearing loss. Probable diagnosis is one definite episode. So the patient should have one definite episode with hearing loss. Now it is recorded with a PTA at least once. The patient should have tinnitus or oral fullness. Now, in a case of definite, the patient will have 2 or more episodes of vertigo that will last for 20 minutes. So now when you do an otoscopy, you will not find anything. Nystagmus is the only case where you can find Meniere's disease, diagnosed Meniere's disease, nystagmus along with tinnitus and vertigo. So for this, the patient should have an episode of attack, right? Nystagmus will only be seen when you have an acute attack. So the definite diagnosis when there are 2 or more episodes of vertigo that will last for 20 minutes, and you can see a hearing loss that will be recorded in a PTA at least once, plus tinnitus or oral fullness. Okay, and definite is when you have an HPE confirmation. I hope until now it's clear. Did you clear about the diagnosis? Otoscopy will show normal. Nystagmus will be normal. Tuning fork test, you will see a Rennie test and a Weber test, right? And Rennie test will be positive, Weber test will be lateralized to the unaffected inner ear, a better ear. You do a pure tone audiometry. So here, PTA means pure tone audiometry. Okay. There is the sensory neural hearing loss in early stages. Usually the low frequencies are affected and the curve will usually rise up and then the higher frequencies are involved. So it's like, this is the graph that we'll have. Okay. So we'll have a hearing loss in decibels and we'll have frequencies, low and high. This is how the graph will look like. So in early stages, what will happen is that the low frequencies are affected. Let's say like this, the low frequencies are affected. And then slowly what happens, they will have high frequencies. Okay. Now, what is Meniere's syndrome? Now, Meniere's disease is something that we know of. What is Meniere's syndrome? So Meniere's disease versus Meniere's syndrome. Meniere's disease is an idiopathic condition, while Meniere's syndrome is because of the resemblance of Meniere's disease. The patient will have episodic vertigo, they will have fluctuating hearing loss, they will have tinnitus, they will have ear fullness, and that will result from a variety of conditions like trauma, or like viral infections, or because of syphilis, or genital or late acquired conditions, or because of otosclerosis or autoimmune disorders. So, secondary Meniere's disease is Meniere's syndrome. I know it's not required because we have already covered the risk factors of Meniere's disease, but then they want to complicate students' lives. So let's select that. Okay, so Meniere's syndrome is also called secondary Meniere's disease. It's on your screen. Please look into it. It is also called secondary Meniere's disease. The symptoms are similar to Meniere's disease. So what are the symptoms of Meniere's disease? Episodic vertigo, tinnitus, sensory neural hearing loss, fullness. Okay. Now, the causes are trauma, viral infection, syphilis, otosclerosis, and autoimmune disorders. Now, on the corner, if you can see, we have variants of Meniere's syndrome, right? So, the variants of Meniere's syndrome are cochlear hydrops, we have vestibular hydrops, and we have Lermio's syndrome. So, what are actually these? So, cochlear hydrops, the cochlear symptoms and signs of Meniere disease are present. So, vertigo is absent usually in these cases. So, see, no vertigo. Okay. And only the cochlear symptoms and signs of Meniere's disease are involved. Only cochlear symptoms and signs of Meniere's disease. Okay. Now, this you will see cochlear hydrops only when the condition becomes chronic. Okay. And there is a block at the level of ductus reunions. So what is ductus reunions? So let's say this is your cochlea. Okay. And you have something called ductus reunions. I'm not able to draw a very good diagram, but then okay. So this will be ductus reunions, this point. Ductus reunions, where it is uniting all the ducts, okay? So what will happen is that there will be a block here in cochlear hydrops. And this will lead to increased endolymphatic pressure to the cochlea only. So now what will happen? The pressure here will increase. Okay. Which type of hearing loss these patients will have? Sensory neural hearing loss, because the cochlea is involved. Now you have another condition called vestibular hydrops. The patient will here typically get attacks of episodic vertigo. Now cochlear hydrops didn't have vertigo episodes. Vestibular hydrops will have episode of vertigo, where the cochlea will actually remain normal. Now, it is also a typical picture of Meniere's disease. Okay. Now, what happens in this that it is also known as recurrent vestibulopathy because the endolymphatic hydrops cannot be demonstrated here when you do a study of temporal bones. So just remember that vestibular hydrops, the patients will have episode of vertigo and no cochlear symptoms will be involved. Now you have something called Lermois syndrome. Here what happens is that in this, the Meniere's disease is seen in reverse order. First, there will be progressive deterioration of hearing loss. Then you will have vertigo. And by the time you will have vertigo, the hearing recovers. So it will come the other way around. Vertigo first comes in, and then you will have hearing loss, right? That's a typical clinical feature of patients with Meniere's disease. But it's the other way around when you have Lermois syndrome. What happens is that you will have deterioration of hearing, and then you will have an attack of vertigo. Now you have something else also called as drop attacks. Okay, it's not mentioned in the slides. You have something called drop attacks. It is usually uncommon and not seen in a lot of Meniere diseases. But there will be a deformation of otolithic membrane of utricle and saccule that will lead to changes in endolymphatic pressure. So now make a note that everything in Meniere's disease is because of disruption of endolymphatic pressure. All right. So if there is a deformation of otolithic membrane of utricle and saccule, that will also increase the endolymphatic pressure and it will lead to Meniere's disease. But that's very rare. But just know there's something called drop attacks or drop hydrops. How will you examine this patient? You have to do an ear examination, which is within the normal limits. Tympanic membranes will be intact. You do a tuning fork test that will show a sensory neural type of hearing loss, right? In acute attacks, nystagmus will be positive. That is usually towards the normal side. Okay. Now, pure tone audiometry. What happens here again? Coming to that point in pure tones audiometry, usually there will be sensory neural hearing loss. I have made the diagram and shown you that sensory neural type of graph you will see. Slowly, it will progress from lower frequencies that are affected and the curve will rise up to higher frequencies are involved. Okay. Then the involved curve becomes flat or it will usually fall. You can see here. Okay. Now, what about the speech audiometry of these patients? There will be a discrimination score usually of 55 to 85. That is not important. But the patients, the attacks, between 55 to 85 between the attacks, but the discrimination ability is not impaired and it is not usually immediately seen. Speech audiometry will not usually be affected in patients of Meniere's disease. Now, here I just want to inform all the students who are listening to this class that speech audiometry will be affected in infants and children who have ENT problems. But if it is an adult, it will not be affected, the speech audiometry. So Meniere's disease is usually seen in patients above 35 years of age. Let's round it up, right? So you will not see any speech audiometry because these patients already know how to talk. Right? So after you know the language, if you have hearing loss, that's not going to affect your language. But if it is an infant or a child, and they are still in a learning process of language and speech learning age. Now, if they have hearing loss, that's going to affect their speech because they will not have clear hearing capacity. All right. So speech audiometry will usually not be affected. Now, if you have a special audiometry test, in special audiometry test, usually it is indicated in cochlear nature of disease when you have sensory neural hearing loss, and this will help you to differentiate from retrocochlear lesions. Like for example, acoustic neuromas. Now, what are acoustic neuromas? I'll just give a brief example. This is your brain. So, right? So you'll have acoustic neuromas on this side. Acoustic neuromas are neuroma also known as schwannomas. These are usually tumors of the nerve cells. So let's say this is your neuron. Right? You have myelin sheath here. The cells of these myelin sheaths are called Schwann cells. Now, if these cells have tumors, that's known as acoustic neuromas. Okay? So what will happen is that the patients will have recruitment test that is positive. They will have something called short increment sensitivity index. You don't have to learn about these tests in detail because it's not subspecialty. Just remember these words called short increment sensitivity test. That should be better than 70% in patients. Now, tone decay test, it is normally, there is decay of less than 2 decibels. Okay. So just remember SIS score of 70, tone decay test should be about 20 decibels, and this indicates a cochlear pathology to rule out if there is a cochlear involvement. It is a retrocochlear lesion. Okay. Now you can do a caloric test. We have already had, I think, 3 classes about caloric test in detail. How do we do caloric test? I'll just mention the mnemonic. Okay. Cold water, opposite. Warm water, same side. Nystagmus. It is related to nystagmus. Go back to our video, then watch that caloric test and read about it. Now we have something called electrocochleography. So now what is electrocochleography? It shows the image, the changes in the Ménière disease. Okay. So normally the ratio to action potential is 30%. But in Meniere's disease, what happened is that summating potential to action potential is greater than 30. %30. So what this will do, it will actually measure the electrical activity of the cochlea and the auditory nerve, which is very important to rule out if the patient is having Meniere's disease involving cochlea. And it will see here, cochlear microphonics, right? It will measure cochlear microphonics. It will measure summating potential. It will measure action potential. Now, summating potential by action potential should be usually more than 30% to find, to confirm the diagnosis that it's a Meniere's disease. Okay. Now, what are the stagings of Meniere's disease? We will have to stage Meniere's disease to make sure what type of treatment the patient requires. So the staging of Meniere's disease is from 1 to 4. So 1 is, it is totally related to an average in decibel in previous 6 months. Okay. So if the patient, it can, by the way, it cannot be done in certain and definite cases of Meniere's disease. Okay. It have to be, it is usually based on the average of pure tone thresholds, like 0.05, 0.5, 1, 2, 3. Okay. And of the worst audiogram, usually that is recorded within the 6 months. So here in previous 6 months, what is the worst audiograph this patient had? According to that, you will stage the patient with Meniere's disease. So if it is stage 1, it should be less than 25. Of course, decibel. If it is stage 2, it should be 26 to 40. If it is stage 3, 41 to 70. If it is stage 4, more than 70. Now, you don't have to by heart this, but then you should know that there are 4 stages to stage the Meniere's disease. That's it. Okay. Now, how do you treat a patient of a chronic condition of Meniere's disease? So, first of all, you will have to give them vestibular sedatives, vasodilators, and diuretics. Okay, you have to give them sedatives, you have to give them vasodilators, you have to give them diuretics. Before diving into that topic, just remember that treatment is usually divided into general measures, management of acute attack, and management of chronic phase. Right, divided it like this. Treatment, conservative management, acute attack, and chronic. So in general, you have to reassure the patient. You have to ask him stop smoking because that is the most important cause. Mostly patients who are smokers are having Meniere's disease because the nicotine in the smoke causes vasospasm. So smoking should be completely stopped. And also you will find out some patients who are smokers will tell you that my ear feels full, right? So that might be because of vasospasm of the nicotine only, but then you can ask them to stop smoking because that really helps with the patients of Meniere's disease. Avoid excessive take of water and, stop taking caffeine, avoid stress, change your lifestyle. All these comes under conservative management. Now, if the patient comes in an acute attack, right, there is severe vertigo with nausea and vomiting, right? And the head movements, if you ask the patient to move head, he'll feel giddy. That's when the patient presents to you or comes to the clinic with an acute attack. So here you can ask the patient to calm down, support him psychologically, give him a bed rest, give him IV fluids and electrolytes if he's constantly vomiting and if you think he is dehydrated, if his oral mucus are dry. And then in that case, you give vestibular sedatives. Now, vestibular sedatives are given to relieve vertigo. They should be either IM or IV depending upon the severity. Okay, right? Vomiting, even after that, pertains, you can give them IV. So first give IM and then wait. It's there, then give IV. So the drugs are dimenhydrinate, and a lot of drugs are there. You don't have to remember the name of the drugs for that. Just remember that you give vestibular sedatives to relieve vertigo in patients with acute uh, attacks of Meniere's disease. Now, diazepam is also given IV, right? So it will actually suppress the activity of medial vestibular nucleus. So I'll just write it down here just for your general knowledge. I'm telling you this. Diazepam. It will, what happen? It will suppress the activity of medial vestibular nucleus. Right, like this. Medial vestibular nucleus suppresses activity. Diazepam. Now, sometimes you can give atropine to the patient if he's having bradycardia. Now, here what happens is that you will have a vertigo that will be causing vagal disturbance. Now, if there is vagal disturbance, there will be abdominal cramp. And because of that, because when there is vagal disturbance, when there is vagal tone disturbance, when your vagal nerve is stimulated, you will have bradycardia. So if a patient is having bradycardia, you can give him atropine. All right, you can give him atropine to manage the bradycardic stage. On the other hand, we have also wrote here that they can be given vasodilators. So what vasodilators you can give them? You can give them carbogen. Okay, so this carbogen contains 5% carbon dioxide and 95% oxygen. So what will happen is that it will cause cerebral vasodilation and that will improve the circulation to a to the libranite system. So vasodilators, carbogen. 5% carbon dioxide plus CO2, 95%. This will improve the circulation because it will cause cerebral vasodilation. Now, how will you manage the patients with chronic phase? Now, let's say this is only acute. Now, when patients after the acute attack, what you have to, now you have to manage this patient well in an acute attack. Now, if it's a chronic phase, again, you will have to give them vestibular sedatives. Now, here this time, you can give them a drug called probantin 15 mg. Thrice daily. It is very effective drug. All right. You can give them vasodilators, of course. And then you can give them diuretics, sometimes furosemide, this will usually what happens is that furosemide will lead to uh, hypokalemia. So you'll have to give the patients this with potassium supplements, okay? So that you manage it, the electrolyte imbalance. Now, chemical libronectomy with injection of gentamicin, which is a vestibulotoxic, is given in the middle ear daily or weekly. Okay. So now also I have forgot to mention that there are some hormones. So hormones are actually seen and managed in patients with hypothyroidism. So here hormones is mentioned in patients with endocrinal disorders like hypothyroidism. So if the patient is in the condition of Meniere's disease, it is better always to get a thyroid function test done and rule out hypothyroidism first, because hypothyroid patients will usually complain of ear fullness. All right. Now, 80% of patients in Meniere's disease are actually recovered with medical therapy. Conservative management is more than enough. But now, if that doesn't set up, then the next step is then you do a chemical libronectomy. So, gentamicin is usually vestibulotoxic. Remember this. Yeah, yeah. Okay. And it is used in daily or bi-weekly injections in the middle ear. Now, what happens is that this drug will be absorbed through the round window and it will cause destruction of vestibular librinate. Okay, so hearing loss, sometimes severe and profound, and sometimes, patients might be treated with this mode of therapy, but sometimes, okay. So remember chemical libronectomy, which drug we use? We use gentamicin. It is also known as intratympanic gentamicin therapy. It's not mentioned here, right? Okay. Okay, I'll write it down here. Intratympanic gentamicin therapy. All right. Now, there's something called interesting. It is very interesting, something called microwick. So it is a very small wick that is made up of polyvinyl acetate. Okay. It is made up of polyvinyl acetate. It is a wing. That wing is meant to deliver drugs from the external canal to the internal canal, and it will avoid, it is usually avoided, usually indicated in patients where you will have to give them repeated intratympanic injections. So you can make a small wick of a polyvinyl acetate and you can put it in the external ear. But it requires a tympanostomy tube. It requires a garment to be inserted in a tympanic membrane. All right. So this is called a micro wick. Then this wick is soaked in the drug. All right. And this drug is delivered from the round window that will be absorbed in the inner ear. Now, it has been used to deliver steroids. So sometimes you can do steroids, but then in sudden deafness and gentamicin, it might also destroy vestibular librinate in Meniere's disease. So you have to be very cautious about it. Okay, so microwick is a small wick that is made up of polyvinyl acetate. It is meant to deliver drugs from the external ear to the inner ear to avoid repeated intratympanic injections. And it requires a garment to be inserted into a tympanic membrane. Now, intratympanic delivery techniques. So it's either you can give them a direct injection through a tympanostomy tube or chemical libronectomy, where an intratympanic gentamicin is injected. You can see it on your screens. We have already discussed this. Or chemical libronectomy, where you do an intratympanic gentamicin injection. Vestibulotoxic. Remember, gentamicin is vestibulotoxic, not cochleotoxic. Okay, so it is less effective on hearing. So the method is that usually you give it 5 times in a day via tympanostomy tube, or 3 times in a day via macro catheter, or weekly injection for 4 weeks. That's 1 month. Okay, you don't have to remember the dosage, but make sure you know it. Now, there are other ablative procedures that you can do only in a definite Meniere's disease. Now, if you're sure that this patient is having a Meniere's disease, that's only when you can do an ablative procedure. It is a long-standing unilateral Meniere's disease, and that is not have with no evidence of disease in contralateral ear, like an opposite ear at the same time or the time of procedure. So ablative procedures are usually contraindicated in patients with advanced age. So I'll write it down here. Contraindicated in advanced age. All right. Now, surgical treatment. Now, how will you surgically treat the patients with Meniere's disease? Now, there is a conservative procedure and there is a destructive procedure. So what happens in conservative procedure? They are used in cases where vertigo is disabling. All right. So there is a decompression of endolymphatic sac and the endolymphatic shunt operation and sacculotomy. There are three things that they are done. So they are used in cases where vertigo is disabling, but hearing is still useful. Okay. Now, vertigo is interfering with the lifestyle of the patient. It is affecting the normal life of the patient. So that's when you do a surgical conservative procedure. So it is a decompression of an endolymphatic sac because the endolymphatic sac is under the pressure. So there is decompression of endolymphatic sac. Or you can do an endolymphatic shunt operation where you put a tube and connect it to the endolymphatic sac within subarachnoid space. That space will help to drain an excess endolymph. Okay, so it's not mentioned here. You connect a tube to subarachnoid space. All right, or you do something called fixed procedure, not fix. It's fixed procedure where you do a sacculotomy. Now, what is sacculotomy? It is a puncture. It's a procedure where you puncture the saccule with a needle through stapes of foot plate. Okay, and the distended saccule that is close to the staped foot plate can be easily penetrated. Now, Cody stack procedure consists of placing a stainless steel. So there is something called Cody stack procedure as well. So in a fixed procedure, what you do is you puncture the saccule with a needle through the stapes foot plate, and the distended saccule that lies close to the foot plate is penetrated easily. And then you do a Cody stack procedure. That way you place a stainless steel to the stapes foot plate. I think I'm clear about it, right? There's something called sectioning of vestibular nerve, where the nerve is exposed by the retrosigmoid or middle cranial fossa, and then you approach and you selectively section it because it will control vertigo, and it will also preserve the hearing. So sectioning of vestibular nerve is where you enter through the retrosigmoid or middle cranial fossa. Write it down. Enter through rectosigmoid I think I missed a page. Hmm. Rectosigmoid or middle cranial fossa. All right. Now there is ultrasonic destruction of vestibular labyrinth where the cochlear function is preserved. Okay. I repeat. Short, I'll repeat it. First of all, you do a decompression of endolymphatic sac, or you do an endolymphatic shunt operation where the tube is put and you connect the endolymphatic sac with the subarachnoid space, or else you do a sacculotomy, that is also known as a PICC procedure, where where you puncture the saccule with a needle through the staped foot plate, and the distended saccule that lies close to the foot plate is reached, and then you do a Cody stack procedure, that is placing a stainless steel tack through the staped foot plate. All right. Or you can do a section of vestibular nerve where you can expose the vestibular nerve by retrosigmoid or middle cranial fossa, where you preserve the hearing. All right. And this procedure actually helps in controlling vertigo, but it's not usually quite used as often. Now you have something called ultrasonic destruction of vestibular labyrinth, where cochlear function is preserved. Now, what is destructive procedure? Now, the name is very interesting. Now, what happens here is that the surgeons will totally destroy cochlear and vestibular function, and this will be used only when cochlear function is not working. All right. So when there is complete, I'll say, surrendering of cochlea. You destroy the cochlear and vestibular function. And labyrinthectomy is the procedure that comes under destructive procedures, where the membranous labyrinth is completely destroyed. Now, either by opening through the lateral semicircular canal or through the oval window. Okay. Either you enter through a lateral semicircular canal. Okay. Enter through circular canal or by an oval window. All right. So labyrinthectomy, you either create an opening through a lateral semicircular canal or through an oval window, and this gives release from the attack of vertigo. Other than that, you can do an endolymphatic sac decompression. So now what happens is that by this operation, you relieve the pressure. It is decompression. So by this operation, the pressure in the sac is relieved and the patient becomes free of any symptoms. It is either local or general anesthesia that we use, and we do a simple mastoidectomy. And there are three SCCs are delineated. Semicircular canals are delineated. Okay. Now, endolymphatic sac lies close to posterior semicircular canal, keeping in mind something called Donaldson's line. Now, bone in this area is drilled with a diamond burr to expose the sac. Now, this sac, which gets decompressed, relieves the symptoms without affecting hearing. So it is decompression of endolymphatic sac. All right. So this is what you see. All right. This is the picture of a procedure that we do. We create a burr into a bone and we enter inside and we decompress the endolymphatic sac. Now you have something called endolymphatic shunt operation, where you put a tube between the subarachnoid space and endolymphatic sac for drainage of excessive fluid. I have mentioned this before. I have also mentioned sacculotomy, also known as fixed procedure. You can see a diagram here where you chop off the vestibular nerve or a cochlear nerve. Not cochlear nerve, you chop off the vestibular nerve. You preserve cochlear nerve. Vestibular nerve. What is Ménière device therapy? Now, we have something called Ménière's device therapy. So, in this procedure, what happens is that it is absorbed that when there is intermittent positive pressure that is delivered to the inner ear fluids, they will bring some relief to the symptoms of Meniere's disease. Not only vertigo, but tinnitus, earfulness, hearing loss, everything will be improved. So if you induce an intermittent positive pressure waves that can be delivered through this instrument that is known as Meniere's device. Okay, so this is the instrument. This instrument will induce an intermittent positive pressure. And the prerequisite of this therapy is that it is to be performed laryngotomy and then insert a ventilation tube so that this device can be coupled with the external ear canal. And this will keep on delivering the pressure waves to the round window membrane via the ventilation tube. Okay. You can see it on your screens. It increases the middle ear pressure and decreases vertigo. Right? Meniere's device is a handheld air pressure generator. It can be self-administered 3 times in a day. it needs a tympanostomy. Now, it cannot be used without tympanostomy. You will have to do a tympanostomy, and you will have to place a tube, that is government, or right to start the therapy. Now, significant effect, you will see it in first 3 months of the use. Now, the pressure waves will pass through the ventilation tube to the round window and then transmitted to the perilymph. So you can see that it will pass through the ventilation tube. So this is the ventilation tube, and to the round window. This is the round window, and then it will be transmitted to the perilymph, and that will compress the endolymphatic lymphatic. That is the blue. This is blue. This is endolymphatic lymphatic, and this is perilymph, endolymph. And this will redistribute the endolymphatic pressure. Now it will help to exchange the pressure in the ear, and it will cause, relief of Meniere's disease. Now, this is important to learn for your practical exam and external exam. Okay, Meniere's disease. So we'll have a next live class topic of tumors of ear and otalgia, tinnitus and rehabilitation. That's it for today. I hope the class was understandable. Any students who want to ask any sort of question can come up with questions, and we can have doubt clearing sessions before we close the class. Anyone? All right. All right. I think we are done for today. Thanks for watching. Keep following us.